Good evening, everyone. Perfect. So we'll get started. Just wait until everybody takes their seats. Thank you so much. Perfect. Thank you so much. Good evening, everyone, and welcome to the 2019 edition of the World Hospice and Palliative Care Day special lecture. My name is Chris Klinger, and I'm the chair of the End-of-Life Issues theme team for the National Initiative for the Care of the Elderly. I also wear a different hat for Pallium Canada in terms of helping them to develop another course, which is going to be Lead Leaders. It is really our pleasure in terms of the organizing organization, which includes the Institute for Life Course in Aging and the Factor Inventage Faculty of Social Work here at the University of Toronto, and Pallium Canada, as well as the National Initiative for the Care of the Elderly, to bring to you the 2019 edition of the World Hospice and Palliative Care Day special lecture. That lecture is one of those things that are in connection with the World Hospice and Palliative Care Day, which is an international day that actually brings forward knowledge and acknowledgement for hospice and palliative care worldwide. The theme of the day for this year is My Care, My Right, and it is a great opportunity to really bring forward some of the initiatives that are out there worldwide to make sure that everybody has access to good hospice and palliative care, as well as of medications that are so important. Many of you know that Canada is facing an opioid crisis right now, and there's especially also discussion about opioids in the United States of America. So we really need to be mindful about what is happening to this, and also of the role that those medications play, especially towards pain and symptom management, but also in the cure, or at least in the helping to solve some of the pains that are out there in cancer. So in terms of the program of today, I just really wanted to welcome you on behalf of all the organizers, as well as all the sponsoring organizations to this day. And I really wanted to thank you as the audience here in the room to actually make it out today on this rainy and potentially still snowy day here in Canada. Just wanted to also tell you that this lecture is going to be audio recorded. So when you have a couple of questions towards the end of the session, please use the microphones that are at both sides of the room, so that this can also be coming on the recording. Without further ado, I also wanted to introduce the first speaker of the evening, Jeff Moat, who is the Executive Director of Pallium Canada, who will give you a short overview of the organization and the changes that are happening to the organization over the last year. He is then going to introduce Dr. Meier, who is our featured keynote speaker and the recipient of the 2019 World Hospice and Palliative Care Day Special Lecture Award, given by the National Initiative for the Care of the Elderly, the Institute for Life Course in Aging at the University of Toronto, and Pallium Canada. There will be a question and answer session after this. It's going to be moderated by Dr. Esme Fuller-Thompson, who's the director of the Institute for Life Course in Aging here at the University of Toronto. And again, one reminder, for the questions and answer sessions, please use the microphones at both sides of the room. Without further ado, Jeff, over to you for Pallium Canada. Thank you.
Thanks, Chris, and good evening, everyone. It's great to be here, and it's great to be here in such amazing company. I've only ever read about Dr. Meier and her accomplishments, and when I heard that she was going to be here this evening, I thought, what a treat it's going to be to have the privilege to introduce her. So I realized that I stand between you and her, so my comments will be brief this evening because you didn't come here to hear me speak. But I do really appreciate the opportunity to give everyone in the room a little bit of an overview of some of the work that we're doing at Pallium Canada. So thank you for your time and attention this evening. And happy World Hospice and Palliative Care Day, if that's appropriate. I thought I would paint a bit of a scenario, if you will, here in Canada with respect to the case for palliative care. No surprise with any of these points, I'm sure, for most of the individuals in this room. Like many other countries, Canada is facing what I'm calling a demographic tsunami, where we're facing this incredible demographic shift where there will be a dramatic increase in the number of Canadians over the age of 65, and an even greater increase in the percentage of Canadians over 80. And as we know, as our population ages, the prevalence of chronic conditions such as cancer, diabetes, and cardiovascular diseases increase. And people are dying differently than in the past. In the past, Canadians, like others, would die from infectious disease, sudden catastrophic events like a heart attack or a stroke or organ failure. But the reality is nowadays, as a result of advances in healthcare practice and medical practices and care, our declines in health are more gradual. So they're spreading out over a longer period of time. So Canadians are living longer, but they're living with more chronic life-limiting illnesses and disabilities and complex medical conditions that require greater amounts of care and intervention. Only a small portion of Canadians, roughly from what I've read, 15%, will need the type of complex care, that tertiary level care, provided by specialists in residential hospices or in palliative care units. For the rest of us, our needs actually can be met by integrating a palliative care approach into the care that we receive, regardless of the setting that we find ourselves in, such as at home or in long-term care facilities. The other interesting thing, and this is especially true in Canada, with respect to family support challenges, many seniors now aren't benefiting from the presence of family members in remote communities. Many of the younger generation that have grown up and raised in these smaller rural communities have left in seek of employment, either in other provinces, or if they stay in the province, they're moving to more urban centers. So this leaves little choice but for individuals to rely either on paid caregivers or their community to receive the care that they need. There is also a gap between what I'm saying here, desires and reality, when it comes to the location of where people are dying. And a survey that was done by the Canadian Hospice Palliative Care Association, this was back, mind you, in 2013, but I'm sure it hasn't changed that much, found that about 3/4 of Canadians who had a preference would choose to die in their home. And the reality is, that's not what's happening. The vast majority are dying in intensive care units, or nursing homes, or long-term care facilities, or even emergency rooms. So being diagnosed as close to death should no longer be the trigger for Canadians to receive better care, enhanced care, and leading a better life and a better death. Healthcare system focused on curing or treating specific illnesses sometimes forgets to care for the whole person. Lastly, in terms of the case for palliative care in Canada, while there is a general shortage of palliative care specialists, professional services, I think most healthcare professionals would agree and emphasize the need to empower all healthcare professionals with the essential palliative care skills. It is not feasible to rely solely on palliative care specialist teams to deliver all the palliative care needs of a population. We know, we've seen this in research studies time and time again, that introducing a palliative care approach earlier leads to better quality of life, less distress, better use of resources, better care decisions, reduced hospitalizations, emergency department visits, and so on. But the reality is that most healthcare professionals don't have some of those basic palliative care competencies. But research shows that when they are trained up, when they actually do acquire those skills, that access for patients to palliative care increases. So it's our firm belief, and I'm sure this is shared by everyone in the room, that improving palliative care is actually everyone's business. Not just the responsibility of a small number of palliative care specialists who, poor souls, are overwhelmed and overburdened. We all have a role to play. So that just sets up the discussion a little bit. I'll switch gears now, talk a little bit about who we are. So when I paint a situation like that, it sounds quite dire and doom and gloom, and I don't really mean to do that, but we know the challenges facing our system are quite heavy. But we believe at Pallium anyway, we recognize that our leadership role on this issue can be a major part of the solution. So through our work, we've been able to demonstrate that we can build healthcare capacity by ensuring that healthcare professionals have a core set of skills to provide more timely and better care to patients and their families, and that the system is not, as I said before, solely reliant on palliative care specialist teams. We've also demonstrated that we're transforming practice. So it's not just an organization focused on training, but through some of these educational interventions, we're equipping healthcare professionals with the knowledge, the attitude and the comfort levels, and the quality improvement tools to improve the care they ultimately deliver to their patients, and in the process are influencing the settings in which they work. Pallium is also very much committed to evaluating and measuring the impact of our work, and I have a slide that talks a little bit about that. And lastly, and certainly not least, is the empowerment of communities, helping communities build a compassionate, supportive network for people affected by serious illness, end of life, caregiving, and grief. We have the potential to transform our society into a skilled, informed, and compassionate one with respect to palliative care. And if Canadians can't do it, we've lost hope. We're the friendliest people in the world. Pallium has been and will continue to be, with our partners, catalysts to make this happen. So when I talk about capacity building, we help do this by ensuring, as I said before, the healthcare professionals have those core set of skills. We're not trying to turn that primary level or that generalist level into palliative care specialists. Far from it. We're trying to provide them with the core set of skills to provide the palliative care approach to patients and their families. And we've done so in urban, in rural, in remote, and even in Indigenous communities in every single province and territory. So over the past 20 years, we've created a suite of courses called LEAP, which is an acronym for Learning Essential Approaches to Palliative Care. These LEAP courses are accredited by both the College of Family Physicians and the Royal College of Physicians and Surgeons. They're available by different settings, specialty areas, professions. They really support interprofessional learning and multidisciplinary teamwork and collaboration. And learners, after taking our courses, do report stronger networks and connections following their training. LEAP has been funded by Canadians, for the Canadian context and service to Canadians, and is considered to be a gold standard in palliative care education in our country. So that gives you a nice, look at that nice bright slide with all those colors. Those are, if you count them, there's 17, not 18. The 18th one will be LEAP 1 that has already started. But you can see the different courses based on different settings, specialty areas. The left side is what's currently out there. The right is in development, with many of those just on the cusp of being launched. So the reality is that because it's everyone's business, it's not enough just to focus on particular settings or one setting or another. We all have a role to play in this, and I wish we had time to explain the development process. We don't, but suffice to say that there is an impressive list of LEAP courses, as you can see in terms of our learners. Look at the one up on the far right. That's actually near the North Pole, for heaven's sakes. That's Pond Inlet. We have learners from every single province and territory that have taken LEAP courses, and this is data that we've captured in our learning management system since 2014. And if we look at the mix by profession, about 24,000, well, it's closer to 25 now. Since 2014, there's far more that have been trained, but again, since the advent of our learning management system, where we're able to better track this, we have some hard data here. So you can see the steady growth, and we're forecasted to come in at about 7,630. That's probably going to be closer to 8,000, given what I've seen the other day. I'm not going to go through all these examples, but when I talk about transforming practice and settings, there's one example that really stands out as an amazing evidence of how we're able to transform practice. In 2015, the emergency medical services in the provinces of Nova Scotia and PEI collaborated with ourselves and with CFHI and CPAC and local palliative care teams to begin training paramedics in those provinces. Very high rates of transfers from home to emergency departments when paramedics were called to homes of patients with palliative care needs really had been identified as a core issue. Moreover, the paramedics had reported a lack of expertise and comfort in providing a palliative care approach. The project included, among other interventions, education of 100% of paramedics in those two provinces. And at a healthcare system level, this is what's really interesting, the program enabled a decrease in transports to hospital from 60% down to 48% in Nova Scotia. And in PEI, the proportion of patients who were kept at home and not transferred to the emergency department was at 32% by the end of the project, and that far exceeded their target of 25%. So it's estimated that the non-transport rate in PI was approximately 0% prior to the project starting, so it's quite amazing. Also interestingly, were the feedback from patients and families, who also reported better symptom control and quality of life as a result of this intervention. The time commitment to calls was not any greater when the choice was made to treat in the home, thereby indicating that the system can sustain the service longer term. The project has showed improved paramedic comfort and confidence in the provision of palliative care and bridge support for patients and families until the usual care team could take over. When we talk about research-driven, and I wish Dr. Pereira was here to talk about this, he can do a far better job than I can, but this just underscores our commitment to evaluating the impact of our work. Last year, Jose had just wrapped up a 2-year research study that explored, among other things, the impact of our courses on learners' attitudes, comfort levels, and knowledge, and along with their commitments to change. So when a learner completes a LEAP course, they're asked to provide between 3 to 5 commitments that they sign on for, that they're going to change in their practice as a result of having gone through a LEAP course. We capture that in our learning management system, and 4 months afterwards, we follow up to better understand what they were successful at implementing and what they weren't successful at implementing. And those 2 pieces of information are very important, as you can imagine. The study showed statistically significant increases in knowledge, attitudes, and comfort levels pre-post course. 73% of those that responded had implemented the learnings from their LEAP course into practice, things such as goals of care discussions, advanced care planning discussions, getting to those essential conversations. But they also communicated several barriers, which in many cases, we see this coming up over and over again, which is that the reticence of leadership or hospital administration to support this because of a lack of understanding. Hence our desire to want to create, as Chris mentioned before, our LEAP Leaders course. Last month, Pallium Canada and McMaster University announced the creation of the Dr. Joshua Shad Pallium Canada Research Hub, which has been established to conduct research in educational curriculum design and pedagogy, and research the impact that our LEAP courses are having on the healthcare system and on patient outcomes. So that is a very, very exciting work, and we've got several levels of the Kirkpatrick model that we've identified that we seem to be delivering against, but those other 2 pieces are critical, so we're very excited to get going on that. And this hub is also going to be focused on the creation of our country's first Palliative Care Atlas, another project that Chris is leading, an initiative that's going to map out the current strengths, areas of excellence, and gaps across regions and provinces with respect to palliative care service availability. The Atlas will showcase a graphical representation of the status of palliative care in Canada and serve to advance what we're calling a systems thinking approach to the Canadian healthcare system by identifying several benchmarks of excellence in leadership. Atlases, and Dr. Mark could talk, I'm sure, for ages about this, but these exist in many other countries around the world. It doesn't exist in Canada, and we want to be the thought leaders with our partners to get this off the ground. There's a lot of appetite for this, so we're pretty excited about getting going on that. And the last piece, this is more of a pilot, but I wanted to whet your appetite with some of the really interesting work we're doing with a local high-tech company in the Greater Ottawa area and a number of family health teams. We're working on an opportunity to assess the impact of education directly on patient care. So a patient, for example, who is seen by a healthcare professional who has undergone palliative care training can, through this system that they set up, provide feedback on the experience with that healthcare professional and whether or not they felt their needs were addressed. So this feedback to the healthcare professional, of course, and their teams would confirm areas that they're doing very well in and areas or opportunities for improvement. So patients are therefore able to provide direct input on clinical care and education effectiveness, thereby driving all the improvement in these areas. So this is very, very new, and it's just on the cusp, but we're pretty excited about these types of projects. Last, but certainly not least, good grief, our communities. Family caregivers, as we know, provide anywhere between 70 to 80% of the care given in Canadian homes and communities. And these contributions, frankly, relieve our government of public costs to the tune of about $26 billion, if they were to be replaced by paid workers. And few of these individuals have the life skills related to dealing with life-limiting illnesses or life-threatening illnesses, and few understand palliative care, and many associate only with dying. So just as we've played a leadership in building capacity among healthcare professionals by training them on the palliative care approach, we believe we're ideally positioned to extend this expertise and approach by helping build capacity at the community level through a number of initiatives that I have listed here. I won't go into them, but happy to talk to anyone about them after. And we do this by equipping community leaders or communities themselves to support individuals by providing them with tools to self-organize. And how do they get a compassionate community off the ground? That's the theory of practice that we've adopted as part of our work. So it's a concerned group of individuals that provide the compassion, the care, and practical supports to patients who are seriously ill or frail and their families. And so this is a very important piece of work that we've been at for several years now. And we help the startup of compassionate communities through our free downloadable online startup toolkit. We've been working with the Canadian Conference of Catholic Bishops on the creation of a faith-based toolkit for clergy and congregations, and that's something that will be adapted to other faith-based groups. A compassionate workplace campaign. We don't have time to get into that, but that is, to me, one of the most exciting initiatives we have underway, because more needs to be done in the workplace to better support those who are acting in a caregiving capacity, not to mention death, dying, and bereavement. And then a Compassionate Communities Exchange, which is an online platform for these various compassionate communities to connect and to share best practice and knowledge transfer and so on. That's a little bit about what we're doing. That's not really why you came here tonight, is it? Thank you for listening to me, and thank you for learning a little bit more about Pallium Canada. I really do appreciate the opportunity to do that. However, I am delighted to be introducing the main event, our main speaker and our cherished guest, Dr. Diane Meier. Diane, I've captured a snippet of your bio, and it doesn't quite do it justice, but this is an amazing lady who has done incredible amounts of work. I want to read this because I think it's just incredible. When I read it a few times because it's just amazing. First off, she's the director at the Center to Advance Palliative Care, CAPC. She's the co-director, Patty and Jay Baker National Palliative Care Center, professor, Department of Geriatrics and Palliative Medicine, Catherine Gazeman, professor of medical ethics at the Icahn School of Medicine of Mount Sinai. Dr. Meier, transformative contributions to the field of palliative care have permanently changed the landscape of mainstream American medicine. She is known as an organizational trailblazer, a pioneering clinician, an innovative medical educator, and an influential author, researcher, advocate, and thought leader. I'm feeling incredibly inadequate. As a founder and director of the Center for Advancing Palliative Care, CAPC, a national organization dedicated to increasing the number of quality of palliative care programs in the U.S., Dr. Meier has put palliative care on the map. So much to learn. In the last 10 years alone, the number of palliative care programs in U.S. hospitals has more than tripled, moving CAPC closer to this goal of bringing palliative care everywhere. As part of her professional mission, Dr. Meier has made a career-long commitment to palliative care education, research, and advocacy. She's a faculty member, as I mentioned, at the Icahn School of Medicine at Mount Sinai in New York, where she currently is the Catherine Gazeman Professor of Medical Ethics. She founded and directed the Hertzberg Palliative Care Institute at Mount Sinai from 1997 to 2013. Dr. Meier has published several books and more than 200 original peer-reviewed papers. It's an honor to have you here this evening, Dr. Meier. Welcome.
So, a lot of what Jeff said is what I'm going to say. The current healthcare system, at least in the States, and it sounds like here as well, is totally mismatched to the needs of the population. And our task is to break through the way we've always done it, the legacy approach to patient care and the practice of medicine and nursing and social work, and start paying attention to the reason that we exist, which is the needs of the patient and the family. And if we really pay attention to the needs of the patient and family, we would blow up the current healthcare system and start all over. That's not easy to do in our country, the lobbying and the profit motive makes it very difficult to shift where the dollars move. in the healthcare system, but we are determined to try. So I have no conflicts to report. One of the things I want to do is talk about why, at least in the States, we do not discuss palliative care and hospice in the same sentence, or the same paragraph, or on a banner. Because the message that it sends, because hospice evokes death and dying, end-of-life care evokes death and dying, and those are emotional terms, and they flood out everything else you're saying. So in the States, we had a patient with metastatic lung cancer on a ventilator in the ICU on dialysis with multi-organ system failure, and one of the house staff, a resident, called in a palliative care consult. And we got this angry call from the oncologist saying, my patient is not ready for palliative care. He's not dying, right? So whether he was dying or not, the perception among many of our colleagues, and unfortunately due to our colleagues, among many patients and families, is that palliative care is for the dying. Well, the fact is, as Jeff pointed out, the vast majority of us live for years, decades even, with serious illness that had major burden, financial, emotional, existential, physical, family caregiving, you name it. Are we saying that they can't have palliative care until they're chain stoking, which is the irregular breathing that occurs in the last hours of life? That's the result of our conflation of palliative care with hospice. So if we're really focused on advancing access to this care for everyone who could benefit from it, we have to get out of our end-of-life corner, because we're doing this ourselves. So these are data from the States, and they basically show the concentration of spending among a very small number of patients. So what this shows is that 1% of patients in the United States drive a quarter of all healthcare spending. 5% of patients drive half of all healthcare spending. Logical, the sickest people cost the most, right? Most of us in this room cost essentially nothing to the healthcare system because we're healthy, right? So if I were a policymaker, I'd look at that and say, all right, half our costs are being driven by this very sick, complex patient population. Is what we pay for and what we do match to their needs? Because we want to get control on quality and control on costs. Well, the answer is it's not. So this fact, which is true in every country on the globe, has not driven policy or the matching of healthcare services to patient needs. In the US, we talk a lot about value. Policymakers talk a lot about value. It sounds very complicated. It's very simple. It's quality in the numerator and cost in the denominator. So a high-value medical intervention is one that, for example, saves millions of lives at trivial or no cost. What's an example of that?
Vaccines.
Vaccines and clean drinking water. The biggest gain in life expectancy in North America occurred between 1900 and 1930, before antibiotics and before vaccines, and it was due to separating sewage from drinking water, chlorinating drinking water. So we talk a lot about our ICUs and our chemotherapy and our stenting and our heart transplants. Trivial impact on human life expectancy. Public health interventions are the major driver of longer life, not modern medicine, even though we like to believe that it's modern medicine. But what the data show is that 5% driving 50% of costs, those are people who need palliative care. And because of the data on the impact of palliative care, both on improving quality and reducing cost, if you want to improve value in your society, you have got to integrate access to palliative care at all stages of serious illness. And just getting this logical fact across to policymakers has been a real struggle, predominantly because they all think it's end-of-life care. So this is a patient I took care of in the Mount Sinai Emergency Department about 8 years ago. And when I met him, he was 88 years old, and he was in the ED for low back pain. And it was about 6 o'clock at night. I was carrying the beeper. I got a page from the attending in the emergency department, who, fortunately, had been my medical student 10 years earlier. I'm old, so I see many waves of students coming through. And he said, oh, Dr. Meier, you probably don't remember me, but I was one of your medical students a while ago. And I don't know if this is an appropriate consult because this patient is not dying. So I'm like, did I teach him nothing? But I have this elderly couple that are abusing the emergency room, that was the language, abusing the emergency room for low back pain. Those of you who are clinicians have heard this language before. We blame the patient for the failures of the design of the healthcare system. So what happened? He had, I'll tell you why he came in, but he described his pain as an 8 out of possible 10 and was taking acetaminophen at toxic doses, 5 grams a day. So Tylenol, I don't know what you call it here, acetaminophen is one of those few drugs with a very narrow therapeutic ratio that is very close to the therapeutic dose is a toxic dose. And because it's over the counter, people don't realize how toxic it is, but at doses around what he was taking, you can destroy your liver. And I've had patients die from not realizing that NyQuil and Dayquil and Tylenol and all those other cold remedies all have a lot of Tylenol in them. And when you take them all at once, you're at very high risk for your liver. So that's what he was doing. And it wasn't working, and he figured, well, if some doesn't work, more will be better, so he just kept taking more and more. Turns out this was his 4th emergency room admission in a several-month period. Twice before, again, because of severe low back pain, and once because of an agitated delirium confusion that was due to constipation, that was due to back pain. And that's how the dementia label got on his chart, by the way, because he showed up in the emergency room with an acute confusional state. Totally preventable, but, and that was on his problem list. He was on a stretcher, curled on his side, all knitted brow, turned away from his wife, refusing to speak to anyone. She was in tears. He was furious that she had called the ambulance again. And here's what he said, "Get me out of here. I told you, I never want to come to the hospital again." He'd been in the ER 3 times previously, and each of those prior ED visits he had been hospitalized. So he didn't want anything to do with us. But here's what his wife said. "He hates being here, but what could I do? The pain was terrible and I couldn't move him myself." Then she called her doctor's office, and in the States, when you call your doctor's office after 5 o'clock, you get a tape. And the tape says, if this is a medical emergency, hang up now and call 911. I assume you don't do that here. Okay. You're bursting all my bubbles. So what had happened is they eat dinner early, so at 5:30. After dinner, he had gone into the bathroom and sat down on the toilet. And when he went to stand up, he couldn't stand up because his back went out. And she tried to pull him up, and she couldn't pull him up. She went and knocked on neighbors' doors. Nobody was home yet because it was only 5:30. It was too early for people to be home. There's no doorman in their building. There's a lot of doorman buildings in Manhattan, and they do a huge amount of elder care. She called her doctor's office, and she did exactly as she was told. The tape said, call 911. She said it was a medical emergency to me. He was screaming in pain. She couldn't move him. There was no one to help her. And this was labeled as abusing the emergency room. Okay. So me and my medical student, I had another third-year medical student with me this time, went down to the ED. At this point, it's about 6:30 at night. He's still turned on his side. ED attending is hoping he doesn't have to admit Mr. B to the hospital because, oh, by the way, I just want to have you look at this photo. You see Mrs. B sews all her own clothing, and she always makes a matching tie for Mr. B. So this is their 60th wedding anniversary party that I was invited to about 7 months after I met them. And you can see that she is a pistol. And you'll see how much of one in just a minute. So we got down there. I looked at Mr. B. I tried to talk to him. He was having none of it. I read the medical record. I read about the 3 prior hospitalizations that essentially did nothing to prevent this problem from recurring. He had had 4 911 calls, 4 ED visits, 3 hospitalizations. On one of these hospitalizations, someone put a catheter in his bladder in the emergency department, which we no longer do, but we did that then, routinely, because it made things easier for the nurses in the ED. And of course, he got a urinary tract infection, and of course, he got sepsis. And he ended up in the intensive care unit, and through some miracle survived. No fault of ours, frankly. And massive functional and cognitive decline from being in the ICU and long hospitalizations. And his wife was at his bedside from 6 in the morning till midnight every night because she was so panicked about what was happening. So she was exhausted and stressed. So what did I do? I noticed that his creatinine was 1.8, so I couldn't give him Motrin or Naproxen or any anti-inflammatory drug because it would destroy his kidneys. Tylenol clearly wasn't cutting it. What else was in the toolbox? Opioids. No, not a single one of the 77 doctors who had seen him on those prior ED visits or hospitalizations was confident enough or knowledgeable enough to use opioids. They thought it was safer to admit him to the hospital. Hospitals, at least in the States, are the 3rd leading cause of death because of medical errors, other issues like what happened to Mr. B with the catheter and the sepsis. Hospitals are very dangerous for 88-year-olds and are to be avoided if at all possible. So I gave him 2.5 milligrams of liquid concentrated morphine. What I would give any one of us as a starting dose would be 10 milligrams of morphine. So it was a quarter of the usual starting dose for an opioid-naive patient. Why did I give such a low dose? I was worried, right? He's 88, he's opioid-naive, he's frail. I didn't want him to stop breathing. I was worried about whether it would adversely affect his mental status. So I gave him 2.5 and I just stood there, I did not leave, which was a lesson for my medical student. You don't put an opioid-naive, especially older person, on opioids and walk away. Because if they do develop respiratory distress, you need to do something about it before they stop breathing. So you need to stand there and see how they tolerate it. Well, unfortunately, after 45 minutes, nothing had changed. He was still on his side, not speaking to anyone, tremendously unhappy and in pain. So I gave him another 2.5 milligrams. So that was 5 milligrams within an hour. 15 minutes later, he was a completely different person. He had turned over on his back. He was holding his wife's hand. He was flirting with the nurses, which she said was back to baseline. He asked to be assisted to walk to the bathroom. He was able to get off the stretcher and walk to the bathroom. So not only did it not adversely affect his mental status and his functional status, it clearly improved both, right? So I taught myself that he could tolerate it at that low dose with benefit in terms of the pain, and that at least in the short term it was safe. What was I worried about? Because I wanted to send him home. What would you be worried about sending an 88-year-old home on morphine with his 83-year-old wife and cognitive impairment? Taking too much. Taking too much, not being able to see the right. I gave them a 1 cc syringe to pull up a quarter of a cc, which is how this drug was concentrated. Could she see it? Did she have the eye-hand coordination to pull up the right dose? So I was worried about that. And then remember, one of his ED admissions was for constipation, which led to an acute confusional state. So I also needed to make sure that she was aggressively managing and preventing that. So I sent the medical student across the street to the pharmacy, and this pharmacy happens to carry opioids. Many New York City pharmacies will not even carry them anymore because of the opioid crisis. So you can't even get these meds for people who need them. And to get the morphine and to get polyethylene glycol powder, Miralax. And we spent another hour with Mrs. B having her practice, pulling up a quarter of a cc over and over until we were convinced, and she was convinced that she could do it accurately, having her mix up a scoop of the Miralax and 8 ounces of water, And until she could tell us back, it's called talk back, how many times she could give that morphine, at what time interval, what to do if she had given 3 doses and it didn't work, which is call, and that she was to give the laxative every day whether he needed it or not. Only then did we put this stuff in a brown paper bag and put them in a taxi and send them home. Now, was I done? I knew nothing about the home situation, right? And so, fortunately, because I'm old and I've been around for a long time, I know everybody, so I know the people who run our house calls practice. We have the largest academic house calls practice in the United States, about 1,000 patients on service, with a 400-person waiting list, because there's not enough money to support what people need. So I called her, at this point it's about 9:30 or 10, and I said, Linda, I just sent an 88-year-old demented patient home on morphine. That got her attention. Can you guys see him tomorrow? And in spite of their 400-person waiting list, they always prioritize people who are in pain or palliative care patients. And they went to see him at 9 o'clock the next morning, where they found a disaster waiting to happen. Loose throw rugs everywhere, electrical wires crisscrossing the floor, a couch. They bought their couch in the 1960s. It was about a foot off the floor. Like if I couldn't stand up from it, that's where they watch TV after dinner in the evening. No grab bars in the bathroom, no elevated toilet seat. And they did what we call the refrigerator biopsy. The only food in the refrigerator was old Chinese food from the restaurant down the street. Because Mrs. B could not go grocery shopping, because Mr. B couldn't go with her because of his back, and he freaked out if she left him alone. So she was just ordering food. Why didn't anybody know about this? She never told her daughter because she didn't want to worry her. And in New York, all the daughters live in California. She lives in California. And you pointed that out earlier, the families that used to generations in the same place, that's really not the case a lot of the time. They also had been very active members of the Greek Orthodox Church that was 2 blocks away, and had stopped going because of Mr. B's mobility problems, and that was their social support. So they were socially isolated, food insecure, and in a very dangerous home environment. And so what the visiting doctor's practice did was call in OT and PT, Visiting Nurses Association. They fitted grab bars. They got him one of those very cool chairs where you push a button and it helps you stand up. Probably the most important thing we did because he stopped having back problems after that. Elevated toilet seat, stopped the problem getting up from the toilet. Grab bar opposite the toilet seat to help him stand up. Ordered Meals on Wheels. And with their permission called their daughter, who now orders food online and has that delivered and visits more because now she knows what's going on. And then they called the minister in the church and they said, you know, Mr. and Mrs. B, and the minister had turned over just at the time that the bees stopped going, so they kind of fell through the cracks. But this congregation, like every congregation, almost every congregation, has a friendly visitor program for shut-ins. And they had a friendly visitor program for shut-ins. They just didn't know that Mr. and Mrs. B were shut-ins. And so now they send 3 days a week a friendly visitor, Monday, Wednesday, and Friday. Monday and Wednesday, it's high school students on community service. Friday, it's a member of the congregation. Sunday, they send a car to pick them up to take them to services. And then they give them lunch with other people in the congregation and take them home. Okay. House calls referral. By the way, the morphine sits in the refrigerator and is essentially unused because it's almost never necessary because of the environmental manipulations that were made. The Visiting Docs program has meaningful 24/7 phone coverage. They are staffed to return phone calls within 10 minutes. Because they know if they don't return an urgent phone call within 10 minutes, the patient will call 911 and go to the ED. And, you know, they have contracts with managed care plans, so if they keep people out of the hospital, those contracts keep going. If they don't keep people out of the hospital, they lose those contracts. So they staff a really responsive 24/7 system. And most of the time, these problems can be addressed by phone. But if you can't reach anybody and you get a tape that says hang up now and call 911, that's exactly what you do. Support for Mrs. B, Meals on Wheels, I mentioned the spiritual support, the housing refurbishment, the social support. That was 8 years ago. He's now 96. He's still living at home with his wife. I think if he has any dementia, it's vascular because it has not progressed. You know, if he falls and breaks his hip, he could die tomorrow. But if I would have predicted he would have been dead much before this, he's still gone. He's not hospice eligible. He's not dying. Now look at these two columns. In the US, which one is easier to get? The left-hand column. Which one is high-value care? Right. So when I'm speaking to medical students or residents, as I was doing last night, I say to them, your job is to make the right-hand column the standard of care and the left-hand column a never event. That's going to take changing how we pay for healthcare, how we educate healthcare workers, how we speak to the public about what they should demand and expect from their healthcare system, and how we pay for care, and shifting money from the acute setting into the community. So remember I told you that the costliest 5% of patients account for half of all healthcare spending. If I asked you to guess what percentage, I'm going to do a pie here, what percentage of the costliest 5% do you think are in the last year of life? Just give me some guesses, wild guesses. Sorry? 20? 50? 80? Who said 10? You're right. Okay, so we assume that all the high spending is among the dying because there are all these news articles that talk about wasted health care among the dying, as if we know. We do not know. They're not counting the spending among those who don't die. They're only counting the spending among those who die. It's a, artifact of bad statistical analysis, right? Only 1 in 10 of the costliest 5% are in the last year of life, not even 6 months. So if we're looking to get control over quality and cost, and we're only focusing on the dying, we're missing the boat. Half of this group have one-time high cost and then get better. And I am in that number because I had a mitral valve repair in February of 2019, which probably cost around $60,000 because of the way we pay for things in our country. So I'm in the costliest 5% for 2019, but I'm not anymore. So in 2020, I will regress back to the mean for my age group. But I don't need palliative care or any kind of special supportive services, so we don't want to target that group either. And yet, in the States, we only look at spending as an indicator of high need and complexity, and that doesn't make sense. Because lots of people are very expensive, but they're benefiting from what we're doing. 40% are the Mr. B's of the world. So if you combine the green and the blue, half of the costliest 5% need palliative care. The green people are persistent high spending year over year over year. Why are they high spending? Because the only thing available is the ED in the hospital after hours. They wouldn't be high spending if we just put the right resources in place, like Mr. and Mrs. B are now getting. So who are the costliest 2.5% then? If we take out the 2.5% that get better, that were expensive. They are just like Mr. B, and their top driver of high spending is functional impairment. Needing another person to get through the day. Do we measure that in our electronic health records? We do not. There is no mandate to record functional status. And what do you guys use? Epic? What do you use? Electronic medical record? Yeah. Just do any of them require functional assessment? because it doesn't help with billing, so we don't measure it. Frailty, cognitive impairment. All the top 3 drivers of being in that high-need, high-cost group are not measured in our electronic health records and are not reflected in claims data, for the most part. Exhausted, overwhelmed family caregivers. Who calls 911? It's always the family caregivers just at the end of their rope. Right? And they get a tape, and they do what they're told. Social and behavioral health challenges, social isolation, food insecurity, mobility problems, trouble getting out. In our country, a huge amount of behavioral health, substance use disorder, and maybe a serious illness. I mean, I don't know if you'd say Mr. B has a serious illness. He's still here, he's 96. I mean, he's old, but he's doing fine. And there are more and more such people in our societies. So these are the things we should be screening for. And if we screen for them with a lens of end-of-life care or hospice, they won't want anything to do with us. Because they're not dying, in fact. And they don't want to be ushered quickly into the grave. Thank you very much. At least patients in the US don't. Maybe in Canada, people are more sanguine. So we developed a new definition of palliative care, similar to the World Health Organization's recent version that does not mention end of life, death, dying, terminal, or hospice. And we think it's really important to use a definition that doesn't mention those things, not only to the public, but also to our colleagues. Because it's our colleagues who are saying to patients, oh, you don't need palliative care, you're not dying. Right? So we've got to have a consistent message and a clear and accurate message, and if we keep trying to make it all things to all people, we'll keep pounding our heads against a brick wall. So we developed this definition at the Center to Advance Palliative Care by talking to the public about what they wanted during a serious illness. And there were a long list of characteristics of services that they might want, and we included good death, end-of-life care, death at home, hospice, none of which were ranked at all by it was about 960 likely voters, oversampling among the elderly was the sample. So they liked specialized medical care because it sounded, like people had training. They liked the term serious illness because it did not imply death, right? My mitral valve prolapse was a serious problem. It required open heart surgery. But it's not a terminal problem. It's not an end-of-life problem, hopefully. They loved the focus on quality of life. That really resonated. That made sense to people. That it addresses pain, symptoms, and stresses of serious illness appealed to people. They really loved that it was provided by a team, and people said it implied that we speak to one another. Because patients' families are well aware that most of the time their doctors don't speak to each other. They don't have time. They don't have interoperable electronic health records. To provide an added layer of support. So here the message is, it's not the consolation prize. It's not what you get when there's nothing more that we can do. It's what you get at the same time as everything we can do. It's better. It's not less. And patients in the States are really worried that we're triaging on their backs, that we're trying to save money on their backs. And they are right. They are absolutely right. Because we are. We're trying to save money. And they're very worried that care that could benefit them will not be offered because of a concern about societal interests. So they're very sensitive to the notion. They're very sensitive if health insurance plans pay for this, because they know why health insurance plans pay for it, to save money. So it's not a myth that they're worried about rationing. There's enough truth to it to justify that feeling. And that it's appropriate at any age, any diagnosis, any stage from diagnosis, and together with curative or life-prolonging disease treatments. My favorite example of this was a 24-year-old we took care of, 15 years ago, named Kate. who showed up in the Mount Sinai ED in a blast crisis for acute myelogenous leukemia. All her skeleton was filled with immature white blood cells. She was in excruciating pain. Nowadays, even then, 15 years ago, we aim for cure in AML in young people, and 75% of them are curable if they have the right genetic types. Palliative care got called on day 6 of her hospital stay, and again, I will never forget this call from the resident who said, "We need your help. Again, this patient is not dying, but we need your help because we have a patient up here who's a manipulative drug seeker." So what were they giving her? Tylenol 3, 2 Tylenol 3 every 6 hours. PRN. Okay? Everything about that is wrong. This is my hospital where house staff don't know what they're doing, right? And because she was screaming, literally, in between doses and clock watching, both the nurses and the interns and residents who were her age labeled her as a drug seeker because of their own incompetence in managing severe acute pain. So we came up, we adjusted her doses, we got we gave it every 4 hours, not every 6 hours. There were rescue doses. We actually started her with a pump, and that really helped. And she became a different person, and with her, the nurses and house staff were really chagrined that they had labeled her as the other, a drug seeker, mainly because they just didn't know how to manage this level of severity of pain. She, by the way, was cured. The palliative care team was at her bedside 3 and 4 times a day through her bone marrow transplant, way more than the oncology team was. But she's fine. We get a Christmas card and a check for $50 every Christmas. And she said to us afterwards that the worst aspect of the entire experience was having been treated as a manipulative drug seeker by people her own age, while she had this life-threatening, terrifying disease. So palliative care is not about dying. It's about suffering and the relief of suffering at any age and any stage. Why do we limit ourselves as if there is no suffering before the dying process? So the conceptual shift is away from this model, the over-the-wall model of throwing people over to hospice on a day that doesn't look much different than the day before, to a different team, a different setting. And after patients have become very attached to and close to the clinicians who are treating their underlying disease, we make them leave their care to get hospice care, which is a huge reason why so many people don't want to. To this model, where we do both, we do it at the same time and at whatever level people need. And this sine wave version was developed by my colleague Sean, because it shows that people's needs go up and down. There are crises, people stabilize, crises, people stabilize. But you don't move to hospice until disease-directed treatments are no longer beneficial. And for most diseases, that time never comes. Heart failure, when do you stop your diuretics, right? You don't. End-stage renal disease, people want to live. COPD, do you stop their steroids and their inhalers, their life-prolonging treatments? No, those are all palliative as well as life-prolonging. And even cancer today is a chronic disease that people live with for a long time. So this notion that there's a clear demarcation between treatments that prolong life and treatments that reduce suffering is a policymaker's fantasy. There is no clear demarcation. In the US, a lot of people have tried to use different language for palliative care to get away from the association with death and dying, which is really confusing people, policymakers and clinicians. Advanced illness management is a favorite term. The public knows what advanced illness is, it's terminal. They don't buy it. Advanced care, same thing. Supportive care is a favorite of the oncologists. Oncologists love supportive care and they're much more likely to refer if the service is called the supportive care service. The problem with it is that we're an international specialty whose name is palliative care. Can't change our journal names, our textbook names, but we do have to get more rigorous and disciplined about not talking about palliative care in the same sentence as hospice. because that sends a message we don't intend. Serious illness care, they are all the same thing. So this is growth in the US in hospital palliative care. We're now at about 2,000 hospitals report having a palliative care team. And all of the honor roll hospitals do. So it's pretty much standard practice in US hospitals, except for we have for-profit hospitals in the US. I think you're spared that, right?
Yes.
Good. So we have for-profit hospitals. They don't invest in palliative care because it doesn't help their quarterly returns. We have a lot of for-profit healthcare in our country, and it's destroying the system. So mapping. We've been mapping access to palliative care for a long time. We put out a state-by-state report card on access to hospital palliative care every 4 or 5 years. This is the 2019 version. The really dark blue are A states, where over 80% of hospitals are providing palliative care. The medium blue are B states, 60 to 80%. The purple and orange states are under 60%. When we first started doing this, the entire South was not only orange, it got an F, which was a different color. There are no more F states. There are very few D states. The great majority of the United States now have an A or B. So that has happened over the last 15 years, and we can see on the different maps how it has improved. But what's the problem with that? Well, they're not in, most people with serious illness are not in the hospital. Most people with serious illness are not hospice eligible. This is the problem. What Mr. B is getting is not the standard practice, and needs to be. If he were in a nursing home, it needs to be the standard practice there. If he goes to see his doctor, who happens to be a colleague of mine who is a cardiologist and practice in the community, that cardiologist needs to know, which he obviously did not, how to manage pain, how to prevent constipation, how to set up a system that would support them after hours. No training, can't blame him. He was never trained to do this. But we need that. So we've just started mapping access to community-based palliative care along the lines of hospital-based palliative care. We identified 2,000 sites of care. You can see they're concentrated in urban areas predominantly. What we found is that over 1,000 nursing homes are delivering palliative care. About 400 clinic or group practices are. 537 in-home palliative care programs. And this was a snowball and convenience sample, so we are undercounting. And the US government doesn't do any annual survey on this. So it's great that you're doing it, and maybe we'll be able to use what you're doing to put pressure on our policymakers. And half of those community-based home palliative care programs are actually run by hospices. Under contract with insurance plans. So it's not standard hospice, and it's people who are not dying, and I will tell you that has been a huge struggle for hospices not to see everything that moves as dying, because that's what they do most of the time. So the shift in the training and the identity and the knowing that shortness of breath doesn't equal morphine, shortness of breath might be pneumonia, might be a pleural effusion, might be heart failure, might be COPD, might be lung cancer, that you actually have to know some medicine to take care of people with multiple chronic conditions. You can't just treat symptoms. So the data are clear on palliative care's impact on value. On the left column, you can see all of the quality measures that have repeatedly been shown to improve, including length of life. There are now 5 studies, mostly in cancer, suggesting that various palliative care interventions actually prolong life. It's really interesting when you say this to a public audience, they're like, of course. Of course the people aren't completely stressed out and terrified and get their questions answered and get their needs met. Of course they live longer. When you talk to a physician audience, they just don't get it. How could palliative care possibly do anything but hasten death? And so we have audience-specific problems in terms of our messaging as well. And very importantly, the denominator of the value equation, cost, doesn't change unless quality improves. right? Because if you're not delivering high-quality care, if you don't have 24/7 coverage, when that inevitable crisis occurs at 3 in the morning, that patient ends up in the ED in the hospital, and you don't save any money. So the good news is you can't save money unless you are delivering quality in this space. And there's a lot of pressure on all these for-profit entities that are standing up home-based palliative care in the US, but they actually have to know what they're doing and take care of patients. Otherwise, those patients will go to the only place that has to. So it's important to understand that the cost reduction is an epiphenomenon, a side effect of improving quality, and always to lead with that. Because if we lead with it saves money, what does that say to the public? We're rationing. This is less than. So I'm sure you guys have seen this study, New England Journal of Medicine, 9 years ago, a randomized controlled trial of early palliative care in lung cancer at Mass General Hospital, probably the best place to go in the world for lung cancer care. They developed all those new fancy drugs that are letting people live much longer. These patients were randomized to get usual care, which is pretty damn good at Mass General, or usual care plus palliative care delivered by a nurse practitioner. And all the things that they expected to change did change: better quality of life, much lower major depression rates, reduced aggressiveness of care, less chemo in the last 2 weeks, more hospice, less hospitalization. What they didn't expect but found was nearly a 3-month gain in life expectancy. And I had 15 colleagues call me the day this came out and said, how could this be true? It was truly unbelievable to them. So what do you think might be the mechanism of action of better survival? And I've given you a bunch of hints of what that might be.
Educating doctors.
Might be. These patients were much less likely to be hospitalized. Hospitals are really dangerous, especially if you have cancer. Because if you catch C. diff or some other resistant bug in the hospital and you have cancer, you die. So keeping people out of the hospital because they weren't having crisis-precipitated hospitalizations, I don't know whether that was the driver. Depression is an independent predictor of mortality in virtually every population in which it's studied, and there was a massive drop in major depression in the intervention group. But I have to believe that most of the explanation is staying out of the hospital. This was a study done by Camilla Zimmerman, published in Lancet 5 years ago on early palliative care that showed quality outcomes improving. This was a systematic review and meta-analysis by my colleague Dio Cavaleratos, who was at University of Pittsburgh and is moving somewhere in the South now. And they also found quality improvement outcomes, quality of life and function outcomes among the patients. This is a really interesting study done by Ethan Bosch, who is an oncologist. And this did not involve any specialist level palliative care. They gave patients at Memorial Sloan Kettering an app on which they reported their symptoms every day. And they knew they had to do it every day. So they didn't wait for the patient to call in a crisis, because patients don't like to bother their doctors and often wait until they shouldn't have waited. So every day they had to punch in at what level was their shortness of breath, their fatigue, their pain, and any time a symptom was reported at moderate or severe, a nurse called back. So not only were they more likely to complete their cancer chemotherapy and radiation, they were much less likely to be hospitalized, and they had a survival benefit. Now you would think this would now be standard practice, wouldn't you? I mean, it's pretty good data that assessing and controlling symptoms helps people. Still not standard practice, because we hadn't trained oncologists to do this, and most oncologists trained before this study came out, so they don't do it. But this is simple. There are a lot of ways to do this. Everyone has a cell phone. You just have to enable staff, create capacity for staff to monitor this. And those nurses were working with protocols and algorithms, and if what they did didn't work, they had support from palliative care or the oncologist to figure out what to do next. And it just made those patients feel safe. They just knew somebody was there. This was another randomized trial done by Kaiser Permanente, which is a globally budgeted healthcare system, more like yours, in which they randomly assigned people with heart failure, COPD, and cancer to receive either regular Medicare home care, which in our country is short-term and can only continue while you have a skilled need, like wound care or learning to use insulin. And it usually lasts about 4 weeks. And the intervention group in blue got what Mr. B gets, home-based primary and palliative care. And you'll see there are 3 times as many home visits in the palliative care group. And in our country, though, these are all paid for in separate silos, so except at Kaiser. So if I were running this home care agency, I'd say, we can't afford this. I'm sure this is better for patients, but we're going to be bankrupted by this. But because it was Kaiser, they could see the spending everywhere else. Physician office visits, ER visits, hospital days, and nursing home days dropped by more than half. So the return on investment was 4 to 1. So Kaiser does this across its entire system. It pays for it because it can't afford not to. The VA does too, because they are also globally budgeted, the Veterans Administration. You guys are globally budgeted, right? This is logical. You're not globally budgeted?
We are, but we don't need this.
Yes, okay. All right. This is a meta-analysis on cost. It's very clear that cost is reduced. All patient populations, settings, nursing homes, hospitals, office practice, home care. There's no debate. Peter May from Ireland did a meta-analysis published last year that furthered that prior work. So the data, there's no argument on the benefits in terms of value of palliative care for this patient population. Here's the argument why our healthcare systems should care. Concentration of risk and spending in a small subset. Evidence that palliative care improves value. Few strategies simultaneously improve quality and reduce cost. How does it work? So the key is that if you leave out any of the 6 things I'm going to show you, it doesn't work. And one of the problems we've had is people hanging out their shingle and saying they're doing palliative care when they're doing aromatherapy. And that's all they're doing. And I'm sure that helps, but it's not sufficient, right? So you have to have adequately staffed and educated teams in the relevant settings. Adequately staffed. Adequately staffed. Almost never the case. Adequately educated. Most people who work in hospice in the States are right out of nursing school or right out of hospital nursing. They've had no training in palliative care. Screen, then target the highest risk people. So you don't wait till someone's been in the ED 4 times. You screen, your whole system screens. You identify your high risk people early and you match services to their needs. We don't do that. Ask people what matters most to them. Don't ask them what their goals are. They'll look at you cross-eyed like you're talking about football. That's not meaningful language for the public. But if you ask people what matters most to them in the context of their health, their current health, they will answer you with something other than I want to live forever. They will say, I would like to see my garden come up next year. I want to make it to my son's high school graduation. I want to take the family on a cruise. I want to finish writing my book. They have achievable goals, but we don't know them if we don't ask. Support the family, because the family is the linchpin. And expert pain and symptom management. Again, if you don't know how to do that, no matter how good your program is, they will end up in the ED with a symptom crisis. So these are all essential characteristics of a high-quality palliative care program. Oh, 24/7 access, minor detail. Forgot that. Also, so these things cost money. It's not cheap to do this right. It saves more money than it costs, but we should never let them tell us, oh, you can do it with a 0.5 FTE RN. because you can't. And as a professional, you should say no. So I always use the analogy that if I were a surgeon being recruited to a place who said, oh yeah, you can operate here, but there's no OR nurses, there's no post-anesthesia care unit, you wouldn't work there because it wouldn't be safe. Palliative care teams should have the same courage of our convictions and professionalism not to work in unsafe environments. So this issue of goal setting and what is most important, my favorite study on this is a study of 357 senior center participants who were asked to rank order between 3 priorities, what was most important to them. Living longer, remaining independent, or relief from pain and other symptoms. What do you think they put first? Followed by pain and symptom relief, and pun intended, dead last, living longer. How is the healthcare system designed? Just the opposite. Just the opposite. We bring older people into the hospital and don't tell them that the best possible outcome from this total hip replacement or this TAVR, this trans-aortic valve replacement, is that they will spend the rest of their life in a nursing home. And if you told them that, they might make a very different decision, but we don't. We tell them what their risk of death is. That is not the most important outcome. So I'm going to close with another patient I took care of. Her name wasn't Jenny, I changed it to Jenny for this Health Affairs article. And the title of the article is based on what an oncologist said to me when I asked him what he hoped to accomplish by infusing chemotherapy into her brain. He said, I don't want Jenny to think I'm abandoning her. This was a very profound lesson for me. So this is Jenny. I met her in my geriatrics practice. She looked totally out of place. She was basically my age. She came to find me after she had lived 5 years with non-small cell lung cancer, and she kept asking her oncologist what would happen when these treatments stopped working, because she knew she was on borrowed time. And she was a clinical psychologist. And he kept saying, oh, we don't have to worry about that. I have more tricks up my sleeve. And she knew that he couldn't go there. And she really wanted to know what was going to happen when these treatments stopped working, because she was terrified of what dying was like. And he was unable to talk to her about that. That's what she needed to know. So she found me on Google and made an appointment at a different medical center to come see me. And that's what she and her husband wanted to know, what's it like to die? So I said 90% of the time people get sleepier and sleepier. They spend more and more time in bed. They stop eating and drinking because their body can't absorb it after a while because things are shutting down. Then their breathing gets rapid, and then after it's been rapid for a while, their breathing becomes intermittent. There are pauses, and they sink into a coma. And during one of those breathing pauses, you die. 90% of the time. 10% of the time, people get agitated and restless, and we have effective medicines for that. Most of the time, we can manage that at home with medicines you can administer. And if we can't, we have places where we can take care of you. And she and her husband, like, their whole face changed. It was like, that's all they needed. It took me 60 seconds. But the oncologist couldn't even talk about it. Probably had actually never seen someone die as I reflect on it. So he and I co-managed her for 3 more years. She lived 9 years. And I did stuff like antidepressants and opioids for dyspnea and psychostimulants for fatigue, and he continued treating her. And she fortunately responded, and then her brain mets just, she had maxed out on RT and corticosteroids, and she went to see him, and he offered an infusion of chemotherapy and an intrathecal pump into the brain. And Jenny listened to that, and she went home and she called me. She said, what do I think? What do you think I thought? I wanted to jump through the phone and strangle the oncologist, but I'm more grown up these days. I said to Jenny, I really don't know what he's hoping to accomplish, but I'll call him and find out, and one of us will get back to you. So I called him, and I said, Abe, that's his name, I don't have much experience with this procedure, What are you hoping we can accomplish with it? And without hesitating, he said it won't help her. There wasn't even a pause. Then there was a pause because I didn't know what to say. But I took a deep breath and remembered that I am the consultant, I am not the treating physician. And I said, do you want me to encourage her to go ahead with it? And then there was a really awkward and long pause while he reflected on that question. And then he said, I don't want Jenny to think I'm abandoning her. He realized that he was offering something dangerous, futile, burdensome, that might shorten her life in order to symbolize his commitment to her. That he did not know how to stay attached to her or committed to her if he wasn't doing something to her. When of course what she cared about was the relationship. Anyway, at that point he said, no, we're not going to do that. Once he became conscious of what was motivating him, he said no. It's time for hospice. She then lived too long on hospice and almost got discharged. She lived 6 months on hospice. And towards the end of her life, about a week before she died, I went to see her. And I asked the question I usually ask at that stage, which is, how are you feeling inside yourself? Because that's when you get beyond, when was your last bowel movement, what's your pain level, are you sleeping? And I thought she was going to talk to me about her mom, because she was estranged from her mother and hadn't spoken to her in 15 years. And I thought, I'm going to be the palliative care angel that heals this family, right? Very arrogant. And what she said was, I'm really upset because Abe has not once called or visited me since I've been home. The very thing he didn't want to do, abandon her, is what he did. And it caused her tremendous distress. And I did call him when she said that. And I said, Abe, you know, Jenny would really like to see you. And he reacted very angrily. Why? Isn't she home on hospice? There's nothing I can do for her. So sad. I said, she's really grateful to you. She's really fond of you. She wants to say thank you. She wants to say goodbye. And he made his first home visit. She died a few days later. I next saw him at her funeral, and he is now the head of the cancer center, where she got her care, a competing cancer center from ours. And he has 2 full palliative care teams in the cancer center, thanks to Jenny. So she did a lot of good. So what was the problem here? He is an oncologist who never got any training about how to walk with his patients throughout the whole course of illness. It just was not part of his training. So he thought if he wasn't infusing something, he couldn't stick with her. What's the solution? As we heard earlier, the solution is training. And it's unfortunate that it's training because it's really hard to do, to train the entire mid-career healthcare workforce in stuff they didn't get when they were open to learning things. But that's what we are also trying to do, just like you are. So this is Jenny and her husband George and her daughter Sarah on one of the many trips they took during the 9 years that Abe gave them. This is Jenny on that visit where I asked her how she was feeling inside herself. So I'm just going to close with this quote from Einstein. He said, every day I remind myself that my inner and outer life are based on the labors of other men and women, I added that, living and dead, and that I must exert myself in order to give in the same measure as I have received and am still receiving. So thank you very much for the work you do and your interest in this part of our society. I appreciate it.
So much for that powerful, powerful presentation. Now we have places on both sides for people to come up and ask questions. We ask that you do come up to the speaker just because we're recording everything, or to the microphone, so please. And maybe just introduce yourself or your background would be helpful.
Yeah, sure. So the full disclaimer is I actually work for Pallium Canada. My background is actually healthcare. And so as the Director of Business Development for Pallium, I have these conversations every day, but also as an ex-emergency room nurse and ICU provider, I also see the clinical hat. And so my question embedded in here is, you've alluded to it several times amongst your case studies about the conversations of the healthcare professional. Mental health has done a really good job at normalizing mental health, and we've come a long way of that description. I found in my conversations across the hospital settings, the topic of the normalization of palliative care is not there. The hardest people to convince, again, you alluded to this, is the healthcare professionals themselves seem to be the biggest barrier. My question is, how have you, or can you comment on how the normalization of talking about palliative care has gone specifically to the healthcare professionals in the clinical setting?
It's a great question, and again, I have to say the fault, dear ones, is in ourselves because of how we talk about it. We always say hospice and palliative care, or palliative care and hospice. What does the audience remember? Hospice, because that's the emotionally laden word. They don't hear anything else you say. We have got to get our own act together before we're going to get our colleagues to change how they think about this. I will say that in our most recent audience research, we included 400 physicians who participated in the survey. And what was fascinating is the physician approval and recognition of palliative care markedly improved over the last 10 years, mostly among physicians under 40 who trained in a hospital that had a palliative care team. So 20 years ago, there were no palliative care teams, so everybody who finished, my age group and younger, doesn't know what palliative care is, sees the word with hospice everywhere they go, so they think it's about what you do at the end. The younger people who trained in teaching hospitals that have active integrated palliative care teams understand it differently, because they're using it for different reasons. So that's my hope. It's going to take my generation dying off and getting out of the way. Younger people will understand that palliative care is just as legitimate as infectious disease or cardiology, and they will not understand it as synonymous with hospice. But we really do have to think about our own messaging habits, because we're creating a problem.
I know we're having dinner, so I'll have your undivided attention after.
Yes.
But since no one's stepping up to the mic, I briefly mentioned the amazing role that paramedics, and delighted to see there's one of them here, have been playing on the palliative care front. And I'm curious, in the United States, if there are similar examples of that.
So everybody who's taking financial risk, so managed Medicare, managed Medicaid, many private insurers are much more creative than the mainstream healthcare system. Three things that they're doing that are improving access to palliative care is, one, training paramedics and enabling, in many states it requires a change in the law to enable paramedics to actually give pain medicine or manage something in the home rather than transfer. So states have gone to the legislature and gotten the law changed. The second thing is the use of community health workers, which is along the lines of what you were talking about empowering and engaging the community. These community health workers ideally are from the community where the patients are from and are not right out of high school or college. Understand what the culture of beliefs are. So for example, in some southern African American communities in the United States, if your loved one dies in the home, their ghost stays there and everyone has to leave, for example. So they just keep coming back to the hospital to make sure he doesn't die there. So understanding those cultural perceptions is essential to good care. Community health workers are not only better at understanding the understanding and misunderstanding of the patient and family, they're way cheaper. And so there have been several randomized controlled trials showing much better survival, better completion of courses of chemotherapy, much lower hospital utilization with community health workers. And the third thing is telemedicine. So that's growing a lot. Also, the ability to learn how to talk to people through a screen, because it's a skill and it requires training, and build relationship, dramatically more convenient for the patient, far cheaper for the clinicians. Most health insurance in the US now pay for this routinely. So the three novel, innovative approaches to improving access are paramedics, community health workers, and telemedicine. And those are all growing really rapidly.
So two more questions, I guess?
That was an amazing talk. We just have a problem here because to receive palliative home care, you have to have a prognosis of less than a year. So the 8-year thing is beautiful, and I think physicians would be happy to look after patients for that long, but the community supports aren't there.
Yeah.
So I don't know how Kaiser is going to do it, but
Yeah.
maybe we should look to them.
So Mr. B has not been back to the hospital, and the amount of visiting home care he gets is minimal. So it's mostly telephonic. There's an occasional nurse visit to fill his Mediset. It's not a doctor, a nurse, a social worker, a chaplain. It's a dose adjustment. So they can ratchet it up if he has a crisis because he's on the list. But most of the contact is telephonic hovering. And so it's about flexibly matching the services to needs and being able to dose up and dose down, which also does not characterize our health system. You know, we've always done it this way, face-to-face, by a doctor. So we can't even imagine doing it any differently. But all you need is somebody to support testing a new model, right? And then showing that it's cheaper and better. And then hopefully you'll get, you've got rational policymakers in this country. We don't have that. So you can bring those data. But it's going to take our field testing those models and identifying those gaps and closing them.
Okay, the last question here.
Thank you so much for that. Chris Klinker with the National Initiative for the Care of the Elderly in Pallium Canada. I just wanted to second your final point because I think that's an important one, and for everybody who's interested in this one, Health Canada is now putting out an action plan for end-of-life care in Canada for the first time, which is one of those initiatives that are coming out of a longer discussion we had here in the country about what to do with palliative and end-of-life care. So a lot of those elements that you were talking about are at least in the discussion phase right now, and it's also quite interesting to see that there might be a chance for getting more of those services into the community, which is great also for initiatives like compassionate communities. And from my point of view, because I'm also a researcher in the field, they also talk about potentially spending some money on doing some research in the field, which is amazing to see. I'm also a teacher though. I'm one of the professors here teaching one of the courses in aging in palliative care and aging in end-of-life care. And one of the questions that comes up is what changes you actually see, and that's one of those questions that I wanted to ask you because the US is a little bit ahead of us with this, is how about palliative medicine becoming a specialty or subspecialty, which is a relatively recent thing for Canada, in terms of how you see this making an impact and how this might actually change the ballgame for palliative and hospice palliative care.
So most of us working in this field have been rabble-rousers and radicals and attacking the mainstream healthcare system, and we're most comfortable there. We don't like being mainstream, most of us. And so there are many people in the field who are opposed to developing a new specialty. That's the last thing we need is another silo. It's more fragmentation. Every clinician should be doing this. But it was an essential developmental stage to get to the table of organized medicine and to begin to integrate palliative medicine into the genome of American medicine. Board certification, career pathway for young physicians. At the CAPC seminar last week, we had 1,200 people. The majority, for the first time, over 50% were physicians, and they're young. And they're choosing this as their field because it's just as legitimate as cardiology, because it's a specialty. So it's like how you have to make yourself look like everybody else to be seen as valid and worthy in the healthcare, circle of influence. Then, once you've done that, you can say, okay, we're the ones who are going to teach everybody the basic skills that every clinician should have, communication, pain and symptom management, family caregiver support. Don't call it palliative care, because they won't be interested in learning it if you call it that. They know that's that team over there, that's not my job. We don't call it that, we call it skills training and communication of pain and symptom management, because everybody needs that. They don't see it, you know, if I said to an oncologist, you need primary palliative care skills, I don't need primary anything, I'm a specialist oncologist. So, you know, our language to these different audiences, but first you have to be established. Then, just as I learned how to manage hypertension and heart failure from a cardiologist, I don't refer to cardiology for a patient with hypertension or heart failure unless what I do isn't working. Same model. Let the palliative care teams teach the students and the residents and the nursing students and the social work students. And they'll call us when they need us, but hopefully they won't need us the way they do now because we're the only game in town. But you have to be legit first to get to that stage. So that's been the developmental process since, I think we were in 2007, became a specialty. Yeah. Thank you.
And that final comment is very important because I don't think there's anybody who's helped the field be the legit as much as you have.
Thank you.
So I can't think of anybody better to have possibly got the award for the 2019 lecture series. So please, a round of applause. Thank you everyone for coming, and those students in the room, I'm going to make a little pledge or plug. I run the Institute for Life Course in Aging, and if you're not in our collaborative program, we have 2 collaborative programs, and one of them is in palliative, and we'd love to hear you and speak to you more, either myself or my colleague Susan Murphy at the back, who's waving, would be happy to talk to you a little bit about it. And we also have a lecture series and an online workshop series that may be of interest to you with more information at the back. So thank you again for joining us on this rainy night. It was certainly worth the long walk through the rain to hear this fabulous presentation. Thanks so much.